Hi, I'm Kelly Mayer, licensed clinical social worker, and today we're talking about phobias. So the DSM-5 criteria for specific phobias is just any marked fear or anxiety about a specific situation. The clients typically have a very intense, immediate fear and anxiety about some kind of situation. So a lot of typical examples of phobias, you could have phobia of heights, storms, elevators, airplanes, could be animals like dogs, spiders, cockroaches. You could have a fear of heights, of elevators. You could have a fear of enclosed small spaces. You could have an intense fear of public places where it is very crowded and there's a lot of people. There's also a lot of medical-related phobias, like people can have a phobia of doctors, of dentists, of shots, needles, blood pressure cuffs. So there are just many different types of phobias. They can be about a specific object, or they can also be about a specific situation. Typically, those are kind of some of the most common phobias. And so a phobia is really different than a fear because everybody has, some fears. Me personally, I get a little nervous driving over bridges. But a fear is more, it's more of like a reduced anxiety where the person feels a little nervous in a situation, but they can still overcome that anxiety. And they are not having to avoid the situation. But with phobias, the person spends a lot of time trying to avoid these situations because the fear is just so intense. Or they may be forced to face these situations, but they are so anxious that they're having such a difficult time coping, and they're spending a lot of time dreading these situations, worrying and ruminating and feeling very distressed. For phobias, it has to really interfere with the person's life. And the client really perceives an out of proportion threat than what is actually realistically dangerous about the situation. So for example, with spiders, it is realistic. You could get a spider bite, and it is true that could hurt you. I mean, you could end up having to go to the doctor or the hospital with a spider bite. But if the person is, seeing a spider across the room, and they're screaming and they're terrified and they're throwing things and they're beginning to have a panic attack and just really unable to cope. And then that fear might then translate to having a difficult time maybe going outside. Maybe their family wants to go camping, but the individual is just so terrified of seeing a spider that they're not able to go camping with their family. And maybe that's causing a lot of tension. With bridges or elevators or stairs phobia, the person might be avoiding those things. So maybe they work somewhere that is in a 10-story building, but they're so afraid of taking the elevator that now they're having to walk up and down 10 flights of stairs every day, and maybe they're now late to work, or maybe they're just so anxious and they're so exhausted that they're showing up to work sweaty and just very irritable, and they're dreading, going home at the end of the day because they know they're going to have to go down these 10 flights of stairs. So for phobia, you can really see that, that's really the criteria. Is it's not just a fear, because everybody has fears, but it's really taking that fear one step further to where it's really interfering with the person's life. So maybe there could be a fear of just like dirt, and maybe the person's job involves them being outside and having to walk in dirt, and so now it's causing that occupational impairment because they're not able to do their job due to their anxiety. So the phobia is definitely, out of proportion to whatever the actual danger would be for just your average kind of typical person. Another criteria in order for it to be considered a phobia is these symptoms have to be occurring for 6 months or longer. So it does need to be occurring for a really long period of time. And in fact, most clients who come to me with phobias, typically they've been experiencing this phobia for probably years. A lot of times phobias might start in childhood. Sometimes the person might have actually had a really bad experience. Maybe they were attacked by a dog, or maybe they were in an elevator and the elevator malfunctioned and they were trapped there, or maybe they were mowing their lawn and they got, overheated and they started having heart palpitations, and then that turned into a panic attack. So a lot of times there is some type of trigger with phobias that happens, and then as a result, the person, is not really able to deal with that, and so they use avoidance, which avoidance is very common for all the anxiety disorders. Typically involve a good amount of avoidance because that's how the person is trying to cope with their anxiety, is to just avoid those situations. So that is pretty typical with phobias. Now, there are some phobias that just kind of occur randomly, and we're not really sure why they occurred. It just one day the person was really scared of something. And so that does happen sometimes. But I would say most common, there was some type of event that did happen first that, really introduced the person into that phobia. And so sometimes people wonder, why? Like, why do people have phobias? Well, typically, anxiety can be caused by learned behavior. It can run in families. It can also be a bit genetic. And so some people, just their personality is a bit more anxious than other people. And there are actually a lot of neurological things that happen regarding individuals with phobias and just with all the anxiety disorders. So the part of the brain that controls fear and the fight or flight response is the amygdala. And so for people with high anxiety, for people with phobias, maybe multiple phobias, a lot of times their amygdala, it's just overactive. And so they might see a snake from, 100 feet away, and they're just going to completely freak out and be very distressed and overwhelmed and just completely terrified. And so that is a bit of just more of like a biological process where their amygdala is just a bit more, overactive than the typical person. Maybe they see a stick and their brain tells them, oh no, this is super dangerous. This is a snake that's about to attack me. And so that's also very typical for people who have phobias. And you can see how this is just going to cause so much distress in their life, so much impairment, and it's going to really hurt with just their day-to-day functioning because they're not able to do things that other people are able to do who don't have this phobia. A lot of people are also really embarrassed with phobias. They may have difficulty just talking about it or being honest and telling other people. And so again, with the avoidance, they may just typically avoid these types of situations and never really deal with it. And so you might be wondering, what is the treatment for phobias? Well, the best treatment for phobias is what's known as exposure and response prevention therapy, which is known as ERP. And I am trained in ERP, so that is actually a type of therapy that I really enjoy doing. And so with ERP, we set up a series of very small exposures. We go very gradually because somebody who has a phobia is terrified. And so we're never just going to throw them out there and say, oh, you're scared of dogs. Well, I'd like you to go buy a dog this week, because that would be ridiculous. That would be impossible. They're not going to be able to do that. So with ERP therapy, we set up an exposure hierarchy, and we will rank different situations according to what's known as a SUD scale, which stands for Subjective Units of Distress Scale. That's a scale from 0 to 10, with 10 being extreme panic, extreme anxiety, extreme distress, and 0 being no anxiety or just a neutral state. So I'll work with my clients and we'll set up this exposure hierarchy, and we will come up with different situations related to their phobia. and we will go ahead and assign a number. And then that's kind of what we'll do. We'll start tackling that. And there's a lot of different techniques and homework assignments that we can do in sessions. That's not even just going ahead and facing your perceived fear. So we can even do things like having a client look at a picture of an elevator or watching a 2-minute YouTube video of an elevator. We can do things during the session of just talking about elevators. Sometimes just actually using that word could be a suds of 3 or 4 for the client. So we may very well just start there, where during sessions we're just only talking about what they're scared of. Moving on from there, we may do some visualizations during session, where I may walk through with the client, just talking, almost like we're telling a story of them with whatever it is that they're having the phobia about. So if the client is terrified of using a blood pressure cuff, we may just kind of be talking about blood pressure cuffs, maybe telling a story about, them going to the doctor, putting the blood pressure cuff on, how they might feel during that time, removing it off, how they might feel after. And we do things called narrative exposures, which is when we actually write out a story. The client may then have to read that story. We can also do in-session exposures when we get to that point, which we wouldn't do that until we've done all these other things that I mentioned first. In-session exposures, I can be there on the video call when we start doing these gradual exposures with the client, and eventually get the client to the point where they're not using avoidance to cope. So there's many techniques, and that's my job, is I analyze, according to the SUD scale, the different breaking down the different phobia, assigning the number, and then I can use my own clinical judgment and guidance to kind of assess where the client's at, because we never want the client to do too much. We always want to go very slowly, very gradually, and I'm always checking in with the client to make sure that they're feeling comfortable and to make sure that I'm not rushing them. I always tell my ERP clients, always just let me know, give me feedback with how you're feeling, and if you think I'm pushing you too much, just let me know. We can always slow down. Exposures can always be broken down into halves, be broken down into fourths, and I'm very flexible, and I really like to collaborate with my clients, because ERP is very scary for a lot of clients that come to me for sessions. So I just continue to kind of check in, work with my clients, and we go at a very slow, gradual pace to make sure that they're feeling comfortable. But ERP is very effective with phobias, and I've had many clients with phobias that I've been able to work with them on, and they have been able to get better. So hopefully this video kind of helped you to be more educated about phobias, the symptoms, and what the treatment looks like. If you did enjoy this video, feel free just to go ahead, hit like. You can go over to my YouTube channel and follow me so you can get alerted with new videos. Go ahead and like, and you can also comment on my video, or let me know if you have any suggestions for future upcoming videos.